Welcome back to the Reaching Higher podcast. I'm your host, Aaron Strout, and I want to tell you how today's episode came to be because this one is personal. Some of you know that I play bocce, and two of my teammates, Jody and Jeff, also happen to be two of the most diligent listeners to this show. A while back, after they'd caught an episode with Phyllis Farrell on Alzheimer's, they pulled me aside and shared something that's quietly upended their family's life, their daughter, Shannon. Shannon had built exactly the life she wanted, a career in Europe, plenty of travel, then back to California for her MBA at Cal Berkeley. She was seriously into fitness and almost never sick. And then a viral infection changed everything. What followed was 14 years lost, 7 of them in near total isolation. And for most of that time, no name for what was actually wrong. She was told it was anxiety, and then she was told it was depression. She was told more than once that it was all in her head. The real answers? ME/CFS and POTS. They took the better part of a decade to arrive. Shannon and her parents are the reason this episode exists. They brought the topic to me, and Shannon herself helped shape the questions and point me toward the right expert. So you'll hear from Shannon first, in her own words, and then from the expert she and I landed on together. And what an expert Dr. David Putrino is. He's a professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai, where he serves as the Nash Family Director of the Cohen Center for Recovery from Complex Chronic Illness, Director of the Abilities Research Center, and Director of Rehabilitation Innovation for the entire Mount Sinai Health System. David trained as a physical therapist in Australia, earned his PhD in neuroscience, and studied computational neuroscience at Harvard, MIT, and NYU. So, pretty educated guy. In 2019, he was named Global Australian of the Year for his contributions to healthcare. His team has cared for more than 3,000 long COVID patients and published in journals as prestigious as Nature. And his work has been featured everywhere from the Wall Street Journal to the BBC to Time and Wired magazine. He's also, and I love this, an official medical provider for Red Bull's sponsored athletes, which hints at the remarkable range of people he treats, from elite competitors to some of the most disabled patients in the country. He recently sat on the HHS Long COVID Roundtable, and he's running some of the most promising clinical trials in the field today. In short, the man is literally doing God's work, and I could not be more grateful that he made time. One more thing before we dive in. This is the final episode of Season 2. Of course, we'll be back with Season 3 in September. So to every single one of you who has tuned in, shared an episode, or reached out this season, I want to thank you. You are the reason we do this, and it genuinely means the world to me. So with that, let's reach higher. First up, Shannon Riley. Well, Shannon, I'm really excited to try this new format to the show, which is having someone on that's brought to my attention an issue that's a very important issue that we'll get into, and then to have an expert that you and I sort of triangulated on in Dr. David Putrino. But welcome to the show.
Great. Well, thanks for having me.
Thank you for being here, and thank you for all your help with questions and helping me identify the right person. So one of the things I always like to do with the show, irrespective of who it is I like to go back to the beginning. And you're a patient, and we're going to sort of get your perspective, which is an incredibly important perspective on this particular topic. So when did you first know something was really wrong? Both POTS and ME/CFS have long histories of patients being told it's anxiety, right? Which I'm sure is maddening, or that it's a lie, that it's all in their head. What did your sort of road to diagnosis originally look like?
Yeah, so it was definitely a long one. And I would say that
2012, if I'm not mistaken.
2012, that's correct. So I think similar to many people's stories is that it started with basically kind of an unknown viral infection I had in 2012. And I was in my second year of business school. And I had the acute infection. But then afterwards, suddenly I realized I was struggling to get out of bed to get to class. I would have an assignment due and I would literally just stare at the computer screen. And I think the best way to describe it is this kind of if your brain was kind of, you're pushing it to failure, the way you might do if you're kind of doing a last rep, or maybe like you think of a marathon runner who does that kind of final sprint, but then collapses right before the finish line simply because their bodies just give out. And that's literally what happens to your brain. It's very frustrating when they call it brain fog because it doesn't quite cover the level of disability that occurs. So these things were happening. I obviously went to the doctor, and like you just talked about, I was told I was just depressed. So I was put on antidepressants and told just to kind of get on with things. And I think the challenge is I was 31. I never really had health issues. I didn't really understand the healthcare system. And so I just believed the doctors what they said. And then I started to get a bit better. And I think what was happening was I would be fine and then I would have these crashes. And of course, now we know that those are called PEM, so post-exertional malaise, which is a diagnostic criteria for ME/CFS. But at the time, I just thought, oh gosh, I'm getting really sick, or I'm just stressed, I'm overdoing it. But basically, I'd be fine. I'd be in bed for several days. I'd get better, not quite the same baseline. And then this just kept happening over and over and over again. So by 2013, I started to get lightheadedness, chest pain. My doctor sent me to the hospital. And I remember very distinctly being told that I was manifesting symptoms in my head. And I was referred to a psychiatrist to undergo cognitive behavioral therapy to overcome my false illness beliefs. And unfortunately, this is extremely common. And again, I believed them. So meanwhile, my health just kind of worsened and worsened. And eventually, a friend of mine insisted I would see a private doctor. And I got very lucky because he had just heard of something called dysautonomia, which is a dysfunction of your autonomic nervous system, controls kind of your fight or flight responses, as well as kind of your heart rate, blood pressure, etc. And so he knew which tests to run, including the tilt table test, which I failed miserably. And so when I went back in to review the test results, he basically said, okay, we figured out what's wrong with you. You have something called dysautonomia. Don't know anything about it, but at least now we can say that you're not crazy. And they literally shook my hand and then showed me the door, and that was it. And it's kind of a very mixed emotion thing because you think, finally, I've got something wrong with me. I am not crazy. But at the same time, you have zero medical support, no help. So that just kind of went on for years. I kept trying to work. And what was happening was I was having trouble staying conscious. So I would have to literally fight to stay conscious. It's a horrible feeling because basically you're not getting the right blood and oxygen to your brain and organs. Your body is telling you to get down before it makes you get down. And then, of course, I was getting the crashes worse and worse. And the last few years of my working career, I was basically bedridden outside of going to the office. Come home from work, in bed. Come home on Fridays, I was in bed till Monday morning. And then, of course, people ask me how was my weekend, and I would just lie and I make things up because I was terrified that people knew how ill I was. That would be a kind of career suicide. So this went on for several years, but eventually got to the point where I couldn't get out of bed on Mondays anymore. And I finally had to leave a career that I had worked incredibly hard to keep. And so at that time, I still had just the POTS diagnosis. And I think the challenge is that because I just had that diagnosis, all my symptoms were attributed to that. No one ever talked about ME to me. So when I took time off work, I thought, if I just exercise more, if I just do more mindfulness, I spend a fortune on wellness clinics, alternative therapies, neuroplastic, brain retraining programs that we all kind of fall for, just because you're so incredibly desperate to get better. But by 2019, I realized that I'd gotten so ill that I could not live independently anymore. And at that time, I was living in England, and my parents had to come get me and bring me back to California. And to be 38 at that time, who I'd always been a very strong, independent woman, to have to then come back and then move into your parents' house is extremely difficult. And I think that's when I really started to doubt the doctors. And I knew that there's something actually really, truly wrong with me. I was at the point where I could barely speak. I would probably speak to my parents maybe 15, 20 minutes a day. I stopped contact with all my friends. I could shower maybe twice a week because showering was so difficult. And I turned to Reddit, as you do, and I actually found a group. And it was interesting. It's a group for people with ME, and I started reading their stories, and it was kind of a light bulb moment when I realized that these people were describing my life. And also through them, I was able to find a doctor in the Bay Area where I'm now located. And finally, after I believe it must have been 7 or 8 years of symptoms, I was officially diagnosed with ME. So that was the journey to get the final ME CFS diagnosis.
Well, I'm sorry that you had to go through that and that you're still going through it, although there's a little bit of a silver lining in terms of the story as we talk about it. So you had a diagnosis, but no treatment or answer. So I'm guessing in some ways it's great. It's like, okay, I finally kind of know what it is, or I think I know what it is. But when you don't have anything that's going to fix it, in some ways, I'm guessing that probably is even as hopeless, if not more hopeless. So what do the next few years look like after you finally, through Reddit and through talking to the right people, got this diagnosis?
Yeah, so I think it's interesting. Even though I knew that there was no treatment, no cure, they estimate there's about a 5% recovery rate, drops to zero after about 2 years. By then, I've been sick for, I believe, close to 10. I think mentally, though, to finally have a doctor that just believed me and could tell me what was wrong with me was actually a huge relief. So even though it wasn't like, here's the cure, I felt immensely better just from that fact alone. And then because she was a private doctor, we were basically started, I met her every 3 months and I would do off-label medications. I think after about 6 years, I've tried dozens of medications, supplements, experimental treatments, different testing, etc. And many of them didn't work, but some would give me kind of 1 or 2% improvement. And that kind of gives you a bit of hope, even though I never thought I would actually really get better.
Well, that's helpful, right? And I think even having a little bit of hope gives you a lot of bit of like encouragement. And I can only imagine what the having someone that it doesn't believe in you, right? And to your point, we are trained by the system, believe what the doctors say. I know just even from like a childbirth perspective, my wife, our first daughter, was a undiagnosed breech baby,
Oh,
and
gee,
like,
yeah.
don't worry, it's fine. And my wife's like, I know something's wrong. Like something is wrong with the way this feels, even though I've never had a baby before. So good for you for continuing to push and to push back. I do want to fast forward a little bit because part of why we're talking and part of what we sort of connected on is there is something that you've recently been turned onto or semi recently that has created significant improvement. So let's talk a little bit about that. I think it might be part of this miracle drug family of GLP-1s.
It is indeed. Yeah. So it's pretty wild. I basically had spent 7 years living in the guest bedroom of my parents, completely isolated from the world. Rarely left the house, was almost entirely bedbound. And that's kind of day after day, week after week. And so I got to the point where when I meet the doctor and try a new drug, it was kind of like, okay, cautious optimism, but it's not really going to help. But interestingly, in December, she put me on tirzepatide, which of course is a GLP-1. And it was the usual look, there's no research for this for ME. There's a small study for it for long COVID. They're showing some benefits. Let's give it a go. And when I say this, I'm talking about very, very microdosing. So I started it and it was absolutely amazing because as I slowly titrated up, I went from suddenly being able to, like, I could leave the house. I could actually talk to people. I was reaching out to friends I hadn't spoken to in 7 years. And then through several months, I was able to date again. I actually was able to travel. So I went to Vietnam, which is very hot. So if you have POTS, you would know that that would be kind of the death and torture. But for whatever reason, this tirzepatide, it was absolutely amazing. I was just fine and was finally able to get back to London to see my friends I hadn't seen in 7 years. So I kind of have slowly re-entered the world all through tirzepatide. Would like to quickly caveat that obviously it's worked really well for me. It doesn't necessarily mean it's going to work for everybody, but it's just been an absolute miracle. It's been amazing.
Well, one of the things that David and I talked about is that as being one of them. And there are a number of other treatments. And I think you helped tee this up in terms of the questions that are showing improvement. And it's these, off usage that people weren't
Mm.
necessarily looking for to begin with. And so I love that there are doctors like Dr. David Putrino, who, again, you all will hear after Shannon. I guess the one last question I'd love to hear, because this is a really important one. It's, sometimes it's finding the right doctor. And we did talk about that with David. But you mentioned that when you became too sick to work or be out in the world, you just disappeared and you didn't want to tell anyone. You were ashamed. I think you were frustrated. You were probably a little bit scared. So why share your story now? Obviously, I'm guessing a little bit is you found something that works. And even though GLP-1s may not be for everyone, it's this methodology that you've discovered after, what has it been, 14 years of wandering in the wilderness, right?
Yeah.
So why tell the story now, and like what can people take away from your story? What is their next best action? Sorry, say that 10 times fast.
Yeah, I know. No, I mean, I think the reason it is really difficult because I think there's a lot of pride that takes place, right? So when you get really sick, you don't want to be pitied, nor do you want to be kind of like this inspiration type of thing of what you go through. And so you kind of lose your identity for a long time. And so that's why you basically just go missing. I think the reason I want to share my story is because I feel incredibly lucky because I had basically one, I had support, family, and friends. I think one thing people don't think about is that when doctors don't believe someone with an illness, the friends and family don't believe it either. And it is, there are so many people out there that do not have the support of their family and friends. Two, I had access. So basically, there was a doctor within my area. There's only a handful of doctors in the United States that even treat ME/CFS, and I had one. And of course, I had the financial means. She's a private doctor. So I think, that gives me a privilege that maybe puts me in the top 5, if not top 1% of people with ME. And I think what I want to try to get out of this is to get people understanding that, A, this is a very serious problem. It's a very, very serious illness. And there are possibilities, and people need to be able to get access to medications, to doctors to treat them, to basically be able to experiment. Because the reality is that this is just trial and error right now. They just don't know. There's very limited research, and most people don't even get that chance to get the trial and error. So I'm just hoping that I can get more visibility to basically get people the same access that I was so privileged to have.
Well, we appreciate it. And again, I learned some things in working with you on questions and talking to Dr. David Putrino, things like tick bites, Lyme disease, things like long COVID, things like ME, CFS, and POTS. They all are more related than they're not. They may not have the exact same sort of symptoms, but they are debilitating. And so I'm grateful that you brought this to my attention, as well as your parents, Jody and Jeff, who are my bocce teammates. And I remember they're diligent listeners to the podcast, and they had actually listened to one with Phyllis Farrell talking about Alzheimer's. And they broached the subject, and then we came up with this idea. So Shannon, thank you for being brave. Thank you for working with me. I'm so happy to hear that you're, at least for now, on a better path to recovery. And hopefully this will inspire others to push back on their doctors or find the right doctor and look for the right therapies to help them on their journey so they don't have to suffer as horribly as you have.
Yeah, no, I mean, that is the hope. I think the thing is cautious optimism. And I know that a lot of people are probably listening from the bed. And I think hope was something I used to hate that word because I never, ever thought that I would ever get better. But I think that at least now with long COVID and the research that's being funded into that you just kind of have to hold on, take it day by day. And it's not about hope. It's just that cautious optimism, I think, in terms of the future.
Yeah, that's a good distinction. Well, thank you again for your time. Really appreciate it. And then coming up next, we have Dr. David Putrino.
All right. Thank you.
All right. Well, Dr. David Putrino, it's such a pleasure to have you. Thank you for making the time to join us today.
Oh, thank you for having me.
Of course. So I do, as folks know that listen to this, I love to start with people's sort of backstories. And I had the benefit of hearing some of your backstory from you personally on the Story Collider podcast. So in that, you described your childhood seizure and recovery as the seed for your life's work, right? And I'd love to get this in your own words. I do highly encourage listeners to check it out. It's a short podcast. I'll link to it in the show notes. But give us the short version of the story and tell us how that led to what you do today.
Yeah, I mean, I think the short story is I like many other people around the world, sustained a brain injury when I was younger. And like many people who sustain a brain injury, I was told, or at least at the time, my parents were told that I would not recover from that injury. That the deficits I had at the time, which was complete paralysis down my left side, were going to persist, and they were told, to put me in a care facility, and that would be that.
Thank goodness they didn't. Thank goodness they didn't.
Yeah, that was not really an acceptable diagnosis or prognosis to my parents. And, they really, although they didn't have any formal training whatsoever, they sort of just, figured it out and figured that if my left side wasn't working too hard, they were going to work it extra hard. And miraculously and fortunately, I actually made a full recovery from that state. But it's always been in the back of my mind what had happened, what would have happened if my parents just followed medical advice, standard medical advice at the time. And then as I went more and more into my clinical training, I noted that more and more people around me were giving that advice. People would say things like, you can't expect to walk again, or hope for the hope for the best but prepare for the worst, was the best advice we would give to patients with neurological disabilities. And so I made a lot of my work around always searching for the latest and the best technologies that were available to anyone, and trying to understand, okay, if this technology is so great, why isn't it commonly being used clinically? How do we get it commonly clinically used? How do we make it affordable, accessible, scalable, all those good things? And then as I started to build this approach around brain injury, people started to reach out to me and say, hey, can you do something for chronic pain? Because I really think that that's an area that needs innovation. And can you do that for pediatric rehab? And can you do that for actually high performance medicine, which is where I started working with athletes and military and, and folks who were sort of on the other end of the performance spectrum. And then when COVID hit us in 2020, and we started noticing that some folks were just not recovering from their initial acute COVID infection, we started to do it for COVID. And then we started to realize that there were other folks who needed this as well. There were people with diagnoses of myalgic encephalomyelitis, which is sometimes called chronic fatigue syndrome. There were people with chronic tick and vector-borne illness. They had been bitten by a tick and never fully recovered. And just like, people with brain injury were being told you'll never recover, perhaps more egregiously even, people with these illnesses were being told, I don't actually think there's anything wrong with you. I think maybe you just need to sit down with a cup of tea and, try not being sick. And so obviously that didn't fly with us. And so we built a center around trying to help folks with those conditions get some answers.
Well, thank goodness that you have. And, it's one of the reasons why I had mentioned to you in our little preamble that Shannon Riley, who's a friend, or the daughter of good friends of ours, who has been suffering from ME and POTS-like symptoms. Thank you for saying the full word, because I was afraid to have to spell out what ME was. There's a few others in here that I had to look up and make sure I was pronouncing correctly. But because you mentioned it, and this was fascinating to me, your department is called Rehabilitation and Human Performance. And you cover a striking range, as you just mentioned. One end, Performance 360, so Red Bull sponsored athletes. I think you mentioned the military, the Brooklyn Nets. And then on the other, you have core patients who are among the most disabled in the country. Quite the spectrum. I think you also mentioned children, right, or infants. So does the thinking about performance at the elite end change how you think about energy limits for others? And this is a question Shannon helped me come up with, which I thought was very clever, because I think we never look at it as a range like that, right? You look at people that are high performers, and it's like, oh, woe is me. But I don't think you ever look at that on a scale of 1 to 10. So I'd love to get your thoughts on that.
No, absolutely. I would say that we're always thinking about the spectrum of human performance, and we're always thinking about how we can cross-pollinate from the different areas that we're working within. I think when I first started working with high performance athletes, it actually came from my neurological knowledge, because I've somehow found myself in a sports performance environment, and I started saying some things, and the coaches and the performance experts took note, and they said, well, like, why are you saying that? What that makes good sense to us, but like, what why are you saying that? And I was like, well, that's how you get a stroke patient to acquire a new skill. So I was like, basically all we're doing here is we're trying to teach an adult nervous system to learn to do something better. We do that all the time in a stroke survivor who we're trying to help through a spectrum of recovery, or someone with a spinal cord injury. So it immediately became evident to me that many of these strategies that we were using in neuro rehab were relevant to the athletic performance world, and vice versa. And then as we started to think about infection-associated chronic conditions and illnesses, things like long COVID, ME, similar issues. We have athletes who get what we call burnout, or athlete overtraining syndrome. As every few years there's a new name for an old thing. What happens in athlete overtraining syndrome? Something occurs where an athlete suddenly can't push themselves through a certain threshold. And we see all of the hallmarks of mitochondrial dysfunction. We see, post-exertional malaise. We see muscle pains and aches that come and go. We see extreme fatigue. We see sleep disruption. And so it's really, really helpful for me to be able to see both ends of the spectrum. It's really, really helpful for me to say, well, in athletes, when we're starting to evaluate someone who has burnout, we will test their resting metabolic rate, because often their resting metabolic rate will be through the roof, even when they're just sort of sitting quietly, not expending any energy, which tells us that there's something mitochondrial going on. We did it in long COVID patients, and lo and behold, roughly 60% of our cohort were hypermetabolic, just like an athlete experiencing burnout. So when you're generally speaking, when you're trying to innovate, and this doesn't even need to apply to medicine, it can apply to any form of innovation. The broader your knowledge base and the broader your experiences, the more it gives you to draw from.
Well, it's funny. First of all, I think that's a very smart approach. And second, you don't know this about me, but I started my career back in sort of the analog going to digital, and then digital to community social. And one of the things that was a big inspiration for us was James Surowiecki's wisdom of crowds. And it very much plays into the broader the base you can draw from, the smarter you're going to be, and the more you can innovate. So I love that you sort of have hit the nail on the head. Because you mentioned it, and I know this is probably a little controversial, but you last September, I believe, you sat on the HHS Long COVID Roundtable convened by RFK Jr. This is in relation to the Long COVID. What was that like, and what's your honest read on whether federal action actually follows from that?
Yeah, I will say that it was great to see, anyone from the federal government saying we're taking this seriously, and we're not just talking about long COVID, we're talking about ME, we're talking about chronic Lyme, we're talking about other tick-borne illnesses and other, infection-associated chronic conditions and illnesses. In fact, that phrase was coined by that roundtable to sort of discuss all of these illnesses and disease states that occur when somebody just fails to recover to their baseline level of health after an infection event or an exposure event. And so it was encouraging. I think that the roundtable was a great conversation. It was a great mix of people in terms of there are a few of the sort of like usual faces, people who have been representing the NIH for a number of years, but there were also a people who had just been treating patients out in the wild, like folks who have been solo practitioners who patients had said to HHS, this guy is seeing 1,000 patients, a month and doing some different approaches to the mainstream. You should talk to him. He's probably got some wisdom. And I really appreciated that HHS was listening to that. Secretary Kennedy himself really listened to everybody, asked good questions. I mean, it's public record. You can actually watch the video, but, he was familiar with publications and he was familiar with the literature, which was encouraging. After the meeting, the first action item was getting a website up and having information put on. We released a 120 some page manual for like the work that we do in our clinic, as that was intended as a guide of like, this may not be the be all and end all, but it's what we do. And that HHS immediately put it up on their website and made it available for download as a standard. So I was encouraged by the work that's been happening there. Where I would like to see more pace is, I think we need agencies like ARPA-H really aggressively funding out of the box, next level, next generation solutions. This was an action item at the roundtable. Hasn't happened yet. I really hope that it does. But I also know that, it's one thing to stand up a website. It's quite another to spend a few $100 million. So,
Yeah. Well, that's encouraging, and that's a very balanced answer. I will link out to some of those, and including ARPA-H, because I have a pretty good sense of who they are, but not everyone might, and I don't want to distract us. But thank you for sharing that. The next thing I want to ask, and you've answered this to a little bit of a degree, but maybe just reinforce, because I think it's such an important one, this idea of medical dismissiveness, right? You touched on it on your own experience early days. Certainly it's been a problem with long COVID. It's one of the reasons why when Shannon and I talked, that was something that she dealt with early days, and then we'll get into some of the solutions. But where did that instinct come from, maybe beyond your own experience, or maybe it's solely from your own experience? And, has that ever cost you professionally? Because I'm guessing, as you've alluded to, that's not everyone's cup of tea, this pushback on what the norm answer is. And maybe there is something beyond the like, you're probably not ever going to get better. So like you said, hope for the best, but prepare for the worst.
Yeah. I think the dismissiveness, I think it generally comes from, an insecurity around not having the knowledge necessary to help somebody. There was I can't for the life of me remember exactly. Oh, actually, I can remember who said it. It was Susan Sontag, of course, who wrote that we metaphorize illnesses that we don't understand. And she wrote that about her own experiences when she was diagnosed in the 80s in New York City with bowel cancer. And she was told, you got this cancer because of your personality. You have the cancer personality.
Jesus.
Now, at the time, I mean, we shake our heads and we say, oh my God. But at the time, that was the pinnacle of, medical knowledge, was there was a cancer personality. You can look back to that time and you can find publications written about people with type A personalities who go on to get, bowel cancer. And since the 80s, we've gone from 1980, where someone would confidently tell somebody that, to, 2026, where if you walk into Mount Sinai Hospital today with a cancer, you will be given a personalized treatment regimen based on your age, race, sex, gender, and immunophenotyping of your tumor, and that is what happens when you fully understand an illness, as opposed to poorly understanding an illness and therefore trying to flick it back onto the patient and say, well, I can't figure out what's going on with you, so you must be the problem. And what we've seen in long COVID and ME before it and chronic Lyme is exactly that. I like long COVID and chronic Lyme as such really good examples of this, because there's such an obvious start to the symptoms. Someone will come and say, listen, I got bitten by a tick and I got a big red spot on my arm and I got joint pain and I got dizziness and then I got some antibiotics, but I never got better. And for the last 30 years, they've been pat on the head and told, but why don't we send you off and get you some depression treatment? And I think that now that medical diagnostics is catching up with lived experience of these patients, we're starting to see clear abnormalities in people's physiology who have these symptoms. And now we just need to find effective treatments to address those physiological abnormalities.
Well, great segue to the next question. I'm going to combine two answers just for the sake of time, because there is a real range of off-label medications that are seemingly at least mitigating symptoms of long COVID, ME, CFS, and related comorbidities. Things like beta blockers and low-dose naltrexone. And then I'm going to roll into the next question, which is also, this is how sort of I got onto your track, GLP-1s, GIP agonists, tirzepatides for post-viral, treatments. There's a Lockett trial at Scripps and a lot of patient-reported improvement. So is this signal or is it noise? And I know it's a leading question because I think the answer is it's more signal than noise, but I'd love to get your educated opinion on this one.
No, absolutely. I mean, I think, the way that we approach things and what we talk about often is we say treat drivers, not symptoms. And what we mean by that is so many people with long COVID, ME, chronic Lyme come in with the same symptoms, extreme fatigue, post-exertional malaise, cognitive impairment, chronic pain, migraines, GI disturbances. And but what we have started to see in the research that we're conducting is that many of these folks have these symptoms for different reasons. Some of the most obvious reasons can be a long COVID patient walks through the door, and based on existing publications, maybe at least 30 to 40% of the long COVID patients who walk through the door are experiencing some form of viral persistence, meaning that the SARS-CoV-2 virus never left their body. So that could be driving these fatigue, post-exertional symptoms that they're having. Versus a chronic Lyme patient walks through the door and, they may have persistent Borrelia, which is the bacteria that causes Lyme disease in their system. So two different pathogens that require two different treatments in order to make them feel better. And then we have MCAS, mast cell activation syndrome. Then we have immune dysregulation. Then we have chronic inflammation. Then we have POTS and dysautonomia and vagus nerve dysfunction. All of these different reasons why somebody might be experiencing this same cluster of symptoms. And so because this has been so poorly explored in the past, it's necessary for us to effectively treat that we use off-label treatment approaches. And the extent to which you can make a good educated guess as to what the driver is means that you're more likely to have a good response to an off-label prescription. So if you really, really believe that somebody is locked into a sort of a chronic inflammatory state and you just need to sort of reset whatever is going on in their brainstem that is causing all of this inflammation, a GLP-1 at low dose might be a perfect intervention for that patient. Whereas if you think, look, yeah, this person has chronic inflammation, but what we really need to do is address the two pathogens that are reactivated in their body, well, you may go for something like the Putrino protocol, which is a combination of 3 different antivirals. So, what we tend to do with each patient is not just ask what symptoms are you experiencing, but then do some deeper testing to understand what's driving the symptoms, what is happening behind those symptoms.
Yeah, that totally makes sense. I mean, it's funny. I had a random, we don't have to dive into this, but as you probably know, cancer, I think 50 years ago was just sort of like considered a thing. And now it turns out it's 200 things. I almost wonder if we're going in reverse with this, where you have the 200 things that were identified as individuals. And now you're realizing they're more like 3 or 4 things that all sort of, happen the same way. So interesting how, medicine works that way. I do want to get into sort of the future of everything you're working on, rapamycin, autoimmune subtyping, anything else, is there one development you think might actually reach patients in the next 2 to 3 years? Because I'm sure some of these may be effective, but a lot of times we know the life cycles are 10, 12 years before you can bring something to market.
Yeah, I would say, we have a number of clinical trials that I am confident that are going to be completed, published, and out in the world within the next, 1 to 2 years. I think low-dose rapamycin as a treatment, which is an immunomodulating drug, we've seen a number of promising publications that have been open label clinical trials, which means that there's no control group. You just give everyone the drug. And a lot of people experience benefit from that. So we're now doing a placebo-controlled, randomized controlled trial, which is a higher level of evidence that will show that it is in fact the drug that is causing the improvement and not some sort of placebo effect. We do hope to complete that trial, by the end of this year and have the results out. If the results are favorable, we will be petitioning the FDA to label this drug for long COVID. Similarly, we're trialing a number of different devices. One device is made by a company called Pharion, and they produce a device that delivers a therapy called microtesla magnetic therapy. We've already completed an initial safety feasibility trial. It was a first-in-human trial. And even in a safety trial, we actually saw patients experiencing benefit. So we're feeling very confident about that as we move into a larger pivotal clinical trial, which again, if successful, and it should be completed in the next year to year and a half, the device will be made available to patients, and it will allow a treatment to be labeled for anybody with sort of cognitive impairment as a result of their long COVID diagnosis. We also have a number of different antiviral therapies that we're trialing at the moment, both repurposed HIV drugs, as well as we will be starting a proper randomized controlled trial of the Putrino protocol, which is a trial I mentioned earlier. And we are hoping by the end of this year to also start a very novel clinical trial in using a procedure called mitochondrial transplant. A lot of people with long COVID ME/CFS experience energetic abnormalities. In fact, Rob Wust's group in the Netherlands just yesterday published in Nature a paper showing that people with long COVID and ME who report post-exertional malaise have clear abnormalities in their mitochondrial function that are completely different from what we see in people who are deconditioned cardiovascularly. So it's different processes at play. So the idea that we might be able to infuse these folks with a bolus of mitochondria to help them to deal with this mitochondrial dysfunction is really promising and really exciting. So it's a very new therapy, and we're sort of proceeding very slowly and carefully, but the initial work has been promising, and we hope to get that out to long COVID patients in clinical trial by the end of the year.
Well, it's amazing news, and fingers crossed, hands praying that does work. Last question, then we have a couple of lighter questions, lightning round, and then we'll wrap up. For someone listening who can't find a provider with any knowledge of infection-associated chronic conditions, I'm guessing there are a lot of them, how would you advise them to go about finding a doctor like yourself? You're a little bit of this miracle worker, diamond or 1 in a million. How do they find someone like you that's willing to help them?
Yeah, it's a really tough problem right now. I think there are a lot of advocacy organizations, that actually hold, that have categories of providers in each state. You know, I know that patient-led is one such organization that has a whole list of ME and long COVID literate doctors. If someone is suffering from chronic Lyme disease, similarly, there's an organization called ILADS that keeps a registry of providers that are Lyme literate and can help with providing care. And then also looking online for virtual services, things like RTHM that will provide online care with providers who have compound licenses, meaning that they can practice in multiple states. If you're particularly really struggling to find access, I think that those are all good options.
Awesome. Well, we'll link to those in the show notes. And I guess knowing that you're at Mount Sinai, is there a particular link that you'd like to share where people can find out more about the work you do and, where they can engage you?
Yeah, absolutely. The Cohen Center for Recovery from Complex Chronic Illness, which we call the CORE, is on Mount Sinai. So if you go to the Mount Sinai website and look up the Cohen Center for Recovery from Complex Chronic Illness, or if you just Google that, our website should pop up.
Awesome. And again, we'll include it in the show notes. So 2 final questions. We'll do it quickly. A show or podcast you're currently binging right now. This is to help our listeners who like to hear from smart people, what's keeping them engaged and amused these days.
Yeah, but that's terrible because now I'm going to lose all credibility.
No, I think you're going to gain credibility because people like to know that these smart people I talk to are real people. So,
actually, the show I'm watching right now, I'm watching a Netflix show called Altered Carbon, which is like
interesting,
very dystopian sci-fi, show, and I'd recommend it for people who like dystopian sci-fi, and not for many other people.
Well, we're watching Silo right now, so we're in the dystopian sci-fi genre, so I'll have to give that a listen. Last one, and I'm very curious to hear your answer to this. A band or artist that you'd love to see and would have loved to have seen in concert, ideally one that's no longer around. What's your go-to for that?
Oh, that's a tough one. I can't narrow it down to a band of art or artists, but I can narrow it down to a location and a time, because
love it.
My wife and I always sort of talk about how we wish we could have been in Manchester in the 70s when the punk movement was just coming up.
I love this.
And,
yes.
The Gallagher brothers were running around doing whatever they were doing. And, there was just this thriving punk music scene being born. I think that would have been one of the best music times ever to be around.
That's a brilliant answer, David. I love that. And I think it sums you up in a nutshell. It's like just clever, but not for clever's sake, and a unique answer because, we get a lot of Beatles, we get a lot of Jimi Hendrix, but that's a fantastic answer. And with that, I will say thank you for taking the time. Thank you for all that you do. You're clearly doing God's work, and, it's coming at such a critical time. So really appreciate it.
Thank you so much for having me. Great
chat. Of course.